is a Wits Journal of Clinical Medicine webinar titled, Are We Coping with COVID-19 in South Africa and Africa? My name is Praveen Manga, and I'll be your moderator this afternoon. I'm also the editor of the Wits Journal of Clinical Medicine, and my team and I at the journal, together with our publishers, Wits Press and Sabinet, who hosts our journal online and who are kindly hosting this webinar as well, are all excited to be hosting the session today. So very briefly about the journal. Wits Journal is of Clinical Medicine. It's an online free access journal and publishes articles in all aspects of clinical medicine. Although the journal is housed at Wits, it is open to national as well as international researchers, particularly from South Africa and Africa. It is important to highlight that the journal is now indexed in PubMed, so your published work in Wits Journal is accessible internationally. The journal also ran a very special COVID issue in April. And as far as we are aware, it's the first to publish academic clinical articles about COVID pandemic in South Africa, and for that matter, in the entire African continent. Thank you to the team. So for this afternoon, we have assembled a great team, and I'm sure it will be a highly informative session. After the session, there will be 20 minutes of Q&A, and I'll pose questions to the panel that have been submitted by some of you. There's probably not enough time to answer all, but I will try and go through as many of the questions that we can that have been sent through. So without any further ado, I'm pleased to introduce our first expert, who is Warren Lohman, who's a pathologist, and his major interest is in infectious disease, and is based at Wits Donald Gordon Medical Center. Warren will discuss some important controversies around diagnostic testing. I'm very fascinating to hear Warren's presentation. Warren?
Dr. Lohman,
there we go. Okay, so so discussing some controversies around COVID testing and epidemiological modeling. Next slide, please. So basically, I'm going to get straight to the point, and this is the bottom. This is the bottom line, and the take-home message, and hopefully, I can show you why. The controversy is really around the fact that we have inappropriate use and application of a diagnostic test. This is essentially not a new phenomenon either. We saw it with HIV, TB, CREs, and it took us a great deal of time to understand how to use the various assays effectively and to accept their limitations. But as we all know, diagnostic tests, especially in infectious disease, are far from perfect. So in infectious diseases, our diagnostic assays must be correctly applied and interpreted according to the clinical context, and this requires understanding of the disease. Next slide, please. So when dealing with a new infectious disease entity such as COVID-19, from a diagnostics perspective, we're faced with a lot of uncertainties, and we really need to focus on principles and foundational knowledge that we have around the entity. Using these principles, one can then interpret and integrate new evidence as it becomes available. So two basic principles are following. Number one, this is a respiratory virus. So that's everything from transmission dynamics to diagnostics to infection prevention and control. We should really be applying a similar conceptual framework as we would for other respiratory viruses. The second important principle is that of PCR testing. This is our bread and butter diagnostic tool for COVID, and similarly for other respiratory viruses. Now, it's widely acknowledged that the sensitivity of PCR is excellent, okay? But it is also, unfortunately, its greatest downfall in the diagnosis of infectious diseases. You have to firstly correctly use the assay based on pre-test probability, and then interpret the results in the context of the application and the clinical presentation. And unfortunately, so far, this is where we have fallen short with COVID-19, which is understandable because it's a disease we're still learning about. Next slide. So to illustrate this, I want to use what I call the hourglass analogy. If you imagine the grains of an hourglass being the viral particles, and what we do know about SARS-CoV-2 is that essentially it starts as an upper respiratory tract infection, and then in some, those who don't clear it, progressively moves down the respiratory tract to cause a viral pneumonia. Next slide. Next slide. Yeah. If we apply to this hourglass analogy the viral dynamics, we see, go back please. Yeah. If here we apply the viral dynamics and what we understand about this virus, we know that viral load and transmissibility is highest within the first few days, particularly within the upper respiratory tract. And it gradually decreases until roughly around day 7, 8, where it now either clears or progresses to a viral pneumonia, in which case the viral load would increase in the lower respiratory tract. So if we apply this to diagnostics, you will see that many variables come into play. The viral dynamics itself. So if we sample a patient at day 10, when the patient now presents for admission because they have a viral pneumonia, and we take an upper respiratory tract swab, you're likely to get a negative result because the bulk of the viral load is no longer in the upper respiratory tract. If we sample the lower respiratory tract, however, you would get your positive. So timing in relation to the clinical presentation is very important. Secondly, sample quality and the representation of the sample is also critical. And thirdly, obviously, it's a highly variable situation because, as you can imagine, no two hourglasses, that is, no two patients, are the same. Next slide, please. So coming back to the question then of why the controversy, well, really it's a case of not seeing the wood for the trees. You can imagine, based on the hourglass analogy, that when we use a diagnostic test fairly randomly without taking into account pre-test probability, you will get poor performance. We have, and this is really what we are seeing by using a single diagnostic modality such as PCR to try to cover all eventualities and all scenarios of clinical presentation or clinical scenarios that we're dealing with in terms of COVID. We have PCR, it's being used as a screening assay for asymptomatic people, for admissions to hospitals, early post-exposure. All of this, which obviously would make very little sense if you consider the viral dynamics of this virus. We know that diagnostic tests are not 100% accurate, and it takes time to understand how to apply the assays to improve diagnosis. Again, one just has to think about TB, HIV, CRE. We know the tests are not 100% accurate, but we've learned how to use them and apply them. In the case of SARS-CoV-2, when we apply the diagnostics PCR assay randomly, testing all and sundry, especially employing a PCR assay which we know is highly sensitive, then we are likely to get results that you don't know what they mean and we don't know what to do with. So the real controversy at the end of the day is that the diagnostics, we have to learn about how to apply and use the diagnostics in a rational and clinically relevant manner. And that's a process of learning that we are going through now. Next slide, please. So just briefly, around epidemiological modeling, the main thing that I want to highlight is around transmissibility. Just importantly, understanding viral diagnostic, the viral dynamics and diagnostics are crucial to models because that's what they're built on. And as I've already highlighted, this is still something that we are learning about. So models will all need to be continually revised as we improve our understanding. The one thing regarding the transmissibility that we know about is that the effective reproduction number of this virus can be quite successfully brought down to below 1 with appropriate non-pharmaceutical preventative measures. The problem is these measures are dependent on social and economic factors, both of which are often beyond the control of an individual or community. So these will all impact on any modeling studies that are done. The other important issue is that of superspreaders and amplification events. This is widely known and has been seen throughout the world that amplification events throw any model completely out the window. And these amplification events, as previously alluded to, are largely social and economic constructs. Next slide.
Thank you, Warren. Thank you so much, Warren. So I'm sure there are going to be questions afterwards. And so let's introduce our second speaker. That's Professor Duomo Adu, who's a consultant nephrologist at the University of Ghana Medical School. He's also a board member of our journal. So welcome, and we look forward to your talk.
Thank you very much, Pravin. Can I please have the first slide? Okay, right. So I plan to give you an African perspective on the COVID-19 pandemic. If I have the next slide, please. So COVID-19 infection arrived in Africa in March 2020, and I actually looked for reasons why it shouldn't spread here. Now, spreading in countries with a similar climate, e.g. Brazil, Singapore, India, African Americans and Africans in the UK who share a genetic background with a lot of people from sub-Saharan Africa have a higher mortality from COVID-19 than European Americans or white British. I think in our favor, Africa has a young population. Only 3% of the population of sub-Saharan Africa is aged over 65 years. But nevertheless, I think it's really important that we identify cases, trace contacts, quarantine, isolate cases and contacts, and practice all the usual things, social distancing, hygiene, and face masks. And I'll tell you how Ghana has been approaching this. So in Ghana, since the middle of March to now, about 250,000 COVID-19 SARS-CoV-2 tests have been done, of which 72,000 was routine surveillance. The vast majority were contact tracing, 160,000. And then there are individuals who flew in or came in to Ghana from outside and were mandatorily quarantined. And of those, a significant proportion were positive. And in total, some 9,900 individuals have tested positive, but it's actually now just over 2,000. And the process in Ghana has been to, as shown above, isolate, test, and trace contacts. There was a period of lockdown. We had quite extensive community education in local languages and community engagement, physical, which I think I preferred, social distancing, hand washing, face masks, with bans on public gatherings, churches and mosque closures of schools and universities. If I have the next slide, please. And this shows the trajectory in Ghana, which actually maybe doesn't show up quite as well. So we had our first case in the middle of March. And soon after that, towards the middle of March, there was a ban on public gatherings, universities and schools, churches and mosques were closed. And then at the end of March, there was a lockdown in the two areas where there were lots of cases. That's in Accra, the capital, and Kumasi, which is the second city. Despite that, there was a slow rise, but the lockdown was listed at, I think I was mentioned earlier, because of economic and other problems, on the 20th of April. And then subsequently, there has been this rise, so that we're now just over 10,000 cases. Next slide. I did a survey of physicians from Africa, and I got responses from 11 African countries, actually quite well spread out, east, west, central, and south. All had a national policy. About half used chloroquine, 3/4 use hydroxychloroquine, 90% use azithromycin, and 50% of all the countries that had a period of lockdown. The next slide. I'm now going to show some COVID-19 data from Africa and show the trajectory of selected regions and countries from when a country or region reached 100 cases. And it's on a log scale, so the slope at any time is indicative of the doubling time. If I have the next slide. And this actually shows the increase in Europe, North America, South America, Asia, and Africa. And I think the key thing is that initially the doubling time in Africa, for reasons I can't explain, was slower than in these other countries. But I think that what's now worrying is that the slope of the curve is similar to that in Asia and in South America and shows no sign of flattening out. And so I think that that's a concern. The next slide. And I looked at all the curves from all across Africa. And again, it showed that we're all pretty well spread around the middle, with South Africa at the top and Rwanda at the bottom. But in the main, relatively few countries have been able to flatten the curve. The next slide, please. The one important thing so far is that the proportion of individuals with COVID-19 dying in Africa at 2.4% is lower than in Europe of around about 8% and in the Americas of 5%. So that I think is a positive thing, but may well not persist. Next slide. And this looks at the epidemiological situation in Africa from the 9th of June. So that's 2 days ago. So we've had a total of just over 200,000 cases with 5.830 deaths and a cumulative fatality rate of 2.71%. Next slide. Can the health systems cope? I think all the projections that we have had from Africa have initially, even from WHO, have been, I think, more widely unrealistic, let's put it that way, because WHO suggested that we're going to have 37 million deaths, 4.6 million hospitalizations in the first year, and as I've just shown now, had just over 200,000 deaths. But whether health systems can cope is critically dependent on whether we can flatten the curve. We also need to hope that most people with COVID-19 infection are young and have mild or asymptomatic disease, not requiring admission. I think the current pressure to ease restrictions on movement and gatherings could lead to an increased rate of infection. And in Ghana, the modeling that has been done shows that if we can reduce the R0 to 1.15 or less, we might just cope. Our health system might just cope, but it'd be a close run thing. Next, please. So just to conclude, the rate of increase initially was slower than in Europe and North America, but the curve is comparable to Asia and to South America. So I don't think we've got any room for complacency. Luckily, our mortality appears to be lower for reasons we don't understand. The mortality in African Americans and Blacks in Europe are higher. It may be that we have more asymptomatic cases in Africa. We need to hope that. I think the initial modeling has not really helped us. And to be honest, I think it's a strange and nasty new virus, and it gives us no room for complacency. And I think there's a lot for us to worry about. Thank you for your attention.
Thank you, Duomo. That was an excellent presentation. In the interest of time, let's move on to the next presentation. And it's my pleasure to introduce Professor Firoza Mutara. Firoza is Head of Emergency Medicine at Wits and at Charlotte McShake Hospital. So she's really at the coalface, and she's going to talk to us on preparedness for COVID. Firoza?
Thanks, Prof. So I think, as we all know, healthcare workers have been in the forefront of managing the COVID pandemic. and it's absolutely essential that they go through a process of preparation. And I'm going to go through what we've done at Charlotte. Next slide, please. So from the outset, when COVID first reared its head in China, in Wuhan city, up until the 1st of March, when we had our first cases, we went through a process where we went through panic initially, but then eventually said, look, we've got to deal with this. It's our way, whether we like it or not. And we started from beginning of February, putting things in place to deal with the pandemic. Next slide. So, what did we do? As the first cases came from China, from Asia, from Europe, we had to look at what we could do at Charlotte, particularly as we were a dedicated COVID hospital designated by the Department of Health. Department of Internal Medicine, critical care, and emergency medicine particularly took the forefront in dealing with this, and we started having meetings to put plans into place. What it all was compounded by the fact that we had huge amounts of fake news, conspiracy theories. I think we were all bombarded with messages and social media all the time for those first few weeks, and it was challenging initially to sift through that information. Next slide, please. So what did we do initially? We had to look at innovative ways of doing things, particularly with our limited resources and limited capacity. We put up tents outside our EDs, and initially our COVID approach was mainly for testing and screening patients. And in the first few months of February and March, we had huge numbers of patients that arrived, I think largely out of panic, that we had to then test and screen. Surprisingly, most of those patients, or not surprisingly, most of those patients that we then screened and tested turned out to be negative. Next slide, please. So a big part of what drove everything was the fear, panic, and anxiety that arose out of all the staff. And a large part of it was not knowing, a large part of it was not being able to have proper information, which was constantly changing almost on a daily basis. So we'd put a protocol in place today and tomorrow it would change. And even the guidelines that were coming from WHO and NICD were not static, were static and changing all the time. And then we had to get used to using PPE and different ways of doing things. Next slide. We started embarking on putting up signage, training people on how to put on PPE, how to take it off, and we soon realized that the challenge with doffing the PPE was more critical than putting it on, because that's where we were starting to get staph spread. Next slide. And had to designate our hospital into different color-coded areas. So we've used red, green, and yellow, which have been standard colors allocated to different areas working with PPE, where yellow was a PUI area, red was for COVID areas, and green were for non-COVID areas. And with that, with the illustrations of what PPE had to be worn in those different areas. Next slide. In the middle of all this, the ED staff came up with the innovation of what we called an intubox, which was just an additional barrier layer for frontline staff who were performing aerosolizing procedures such as intubation, and we'll be using it as standard precaution. Next slide. It's also changed completely what we do on a normal basis. So we now have social distancing on ward rounds. As you can see in the left lower corner, our cleaning staff in the top left-hand corner are now standard wearing PPE. Standard uniform is full gowns, visors, N95 masks, and staff have now gotten used to seeing patients in full PPE. Next slide. So from an occupational health perspective, staff fear and panic was a huge driver of what we did. Constant meetings, reassurance, training. We've done baseline screening of all our staff, and there's ongoing monitoring of staff on a daily basis. Protocols and SOPs that we're drawing up are changing on a daily, sometimes weekly basis, depending on new information that's coming through. Next slide. And again, this one and the next slide just show protocols for staff exposure, and we're happy to share these presentations at the end of the presentation. Next slide. So who are the high-risk staff? Obviously, frontline staff, doctors and nurses who are doing aerosolizing procedures, dental workers, ENTs, lab workers. And important that in this whole process, we don't forget people like the porters, cleaners, security, who are working in those areas because they have particularly high risk as well. Additionally, staff who are over 60, male, and who have uncontrolled comorbidities have had to be screened, and we're trying at the moment to redeploy them to non-frontline areas, possibly data collection, administrative areas where they will be at lower risk for exposure. Lessons learned in the whole process is the most important thing I've realized is never to underestimate the fear and anxiety among staff, because that derails the entire program of what you're trying to put into place. Social and psychological support is essential, especially where we've got staff that are positive and reassuring the other staff in that department. Obviously, having PPE and equipment and consumables available, and ongoing training and repeat training are absolutely essential. Next slide. Corporate South Africa has been amazing. We've had donations of lots of stuff, including Red Bull and coffee, which we've needed lots of. And then also donations of essential stuff, hand sanitizer. When the picture in your left lower corner is 2 8-year-old children who broke their piggy banks and bought us hand sanitizer and had it delivered. So the outpouring of support's been amazing and has enabled us to carry on. Next slide. And I think in conclusion, it's just to say that if I've learned anything through this experience is that I'm constantly relearning, redoing, and reviewing what we're doing on a daily basis as things are changing and evolving. But the one thing that I do know is that I won't change the group of people I've done it with, because we wouldn't have been able to achieve what we have up until now. Thank you.
Thank you, Firoza. That was excellent. I'd like to now introduce a colleague of mine who I've worked for many, many, many years, Guy Richards. Professor Richards is Emeritus Professor of Critical Care at the University of Witwatersrand. And he's going to talk to us about, well, up to date about treatment of COVID. Guy?
Less of this many, many years, please. So we're going to be talking briefly about the pharmacological therapy, which obviously started with chloroquine, introduced by President Trump as being the therapy that was going to cure everybody. And that was because it did have potent in vitro activity against the virus. And small observational studies initially suggested more rapid viral clearance and then inhibition of progression to pneumonia. Next one. Next slide. Yeah. So looking at some of the studies, this was one of the earlier ones, 16 Chinese treatment centers with 150 patients and an intention to treat analysis. 75 of them got hydroxychloroquine, big dose, 1200 milligrams daily for 3 days, and then maintenance dose of 800 milligrams daily. The probability of negative conversion by 28 days in the hydroxychloroquine group was 85% versus 81% in the standard care group. So no difference at all in terms of conversion to negativity. Adverse events were 30% in the chloroquine group versus 9% in those that weren't. And those were primarily cardiac. Next one. This was another one thereafter, slightly bigger, 181 patients. These were all patients requiring oxygen, but weren't actually in ICU. So an intermediate severity that they were actually looking at as well. They used a slightly lower dose, 600 milligrams per day within 48 hours of admission versus standard care. And in yellow, as you can see, that the overall survival at day 21 was 89% in the hydroxychloroquine group versus 91% in the standard group. there was no difference in the number that were weaned from oxygen at day 21, and 10% of those on the hydroxychloroquine had ECG abnormalities that required discontinuation. Next one. Another observational study, 1,376 patients. I'm not going to go through it fully, but in the main analysis, there was no significant association between its use, intubation, or death. And the hazard ratio, as you can see, was not significant. No results or no benefit there whatsoever. So almost certainly it has very little effect. Next one. This is the first of the randomized controlled trials. We haven't seen the whole study. This was a preliminary report that came out. The recovery trial, 1,500 patients randomized to chloroquine versus 3,000 to usual care. No significant difference in the primary endpoint of 28-day mortality, 25 versus 23%. And there was also no evidence of benefit on hospital stay duration or other outcomes. So again, I think that really has put paid to it. Remdesivir is the one with lots of excitement at the moment, and there was already one study published in Lancet. The Lancet study indicated that in patients who had started the therapy within 10 days of the onset of symptoms, that there was a decrease in the time that they would take to recover completely. Not a very exciting outcome, but at least it possibly had some positivity. This is the more recent one, a double-blind randomized placebo-controlled trial, adults hospitalized with lower respiratory tract infection, in other words, the pneumonic phase of the disease. They gave a 200 load and then 100 milligrams daily for 9 days or placebo. 1,059 patients. Remdesivir group had a median recovery time of 11 days. In the control group, it was 15 days. So the rate ratio for recovery was 1.32. In other words, the 32% chance of recovering earlier in an earlier time than those that did not receive it. An estimate of mortality, and these were Kaplan-Meier estimates at 14 days, was 7.1% for the Remdesivir versus 11.9% for the controls, with a hazard ratio of death of 0.7, which didn't reach statistical significance. Serious adverse events were much the same in both of those groups. So it has promise, but it's not the wonder drug that people are talking about, and it potentially will shorten time to recovery. Next one. Triple therapy recently reported as well in the Lancet. In this group, they used 14 days of 3 drugs. They used Kaletra or Eluvia, depending on what you call it, the ribavirin, and then 3 doses of 8 million units of interferon beta on alternate days versus Kaletra alone. That's lopinavir, ritonavir. It was 127 patients. The median days from symptom onset to the start of therapy was 5 days, so they gave it early. The combination group had significantly shorter median time to a negative nasopharyngeal swab, which was 7 days, than the controls. Now that's very unexciting because in fact the pharyngeal swabs can in fact remain positive for a prolonged period of time without there being any evidence of infectivity at that stage as well. So again, unexciting in terms of its benefit. Next one. Treatment dose systemic anticoagulation. We know that this disease is not just a disease of the respiratory system, it's also a disease of the vascular system. And this was an observational study again of 2,700 patients that included all forms of anticoagulation that were administered, oral drugs, the NOACs, subcutaneous or IV forms, and it was adjusted for age, sex, ethnicity, BMI, hypertension, heart failure, atrial fib, or type 2 diabetes. And the in-hospital mortality overall was 22.5 versus 22.8, no difference at all. But if you looked at those who were mechanically ventilated, of 395 patients, in-hospital mortality was 29.1% versus 62.7% in those that did not receive anticoagulation. And in multivariate analysis, longer anticoagulant duration had a mortality risk that was reduced a hazard ratio of 0.86, and that was significant, and bleeding events were actually similar. Next one. Corticosteroids, meta-analyses of COVID-19 or treating COVID-19 overall have not shown benefit, but if you look at those patients who are more ill, it's potentially is of benefit. And in China, methylprednisolone was associated with increased survival in patients with ARDS with a very low hazard ratio of 0.38, and that was significant. And in another randomized controlled trial in 17 Spanish ICUs, 139 of 277 patients with ARDS, that's important to note, they were the iller patients. They were given, they were ventilated, and as you can see, on fairly significant parameters as well. They received IV dexamethasone for 20 milligrams for 5 days, and then 10 milligrams for 5 days, or routine care. And those who received the steroids had more ventilator-free days. That was 4.8 days, less ventilator days, and that was significant. And the 60-day mortality was 21% versus 36%, with a difference of 15.3%. Adverse events were not different either between those groups. Next one. Another study that was more recent, patients admitted with pneumonia. There were 396 patients, 46.7% of the patients overall. They were consecutive. They received 1 milligram per kilogram per day of methylpred or equivalent versus 67 controls. The global mortality was 15.1%. The median time to corticosteroid from symptom onset was 10 days. The in-hospital mortality was 13.9% in the corticosteroid group versus 23% in those that did not receive corticosteroid. And there was a relative risk reduction of 0.42, which was significant, as you can see as well. Next one. There is some possibility that some nutritional interventions might make a difference. There are no studies demonstrating this at the moment, but worthwhile looking at. Vitamin C is an extracellular nutritional antioxidant which quenches reactive oxidant species. Zinc, increasing that, impairs replication of SARS-CoV in cell culture. Vitamin D is a negative endocrine regulator of the renin-angiotensin-aldosterone system. And SARS-CoV-2 downregulates ACE2 expression, which is the receptor for the virus, increasing inflammation and injury from neutrophil inflammation and an unbalanced renin-angiotensin-aldosterone system. So vitamin D might have an effect there. Niacin, the presence of both zinc and NAD+ is imperative for the function of a molecule, SIRT1, which can decrease and modulate the levels of TNF-alpha, interleukin-1 beta, and interleukin-6. No studies and purely hypotheses at this stage. Next. Biologics, there are a large number of biologics which are currently being tried because the lethal phase of the disease is in fact a cytokine storm, and modulating cytokine production may well have benefit. The agent which has been most well studied is tocilizumab, which is a humanized monoclonal antibody for rheumatoid arthritis, and it inhibits interleukin-6. Well demonstrated that interleukin-6 increases exponentially during the period of viremia, at which time multi-organ failure occurs, etc. This is one study of 21 patients with very elevated IL-6. They got 400 milligrams, that's one dose stat, led to rapid resolution of fever and improved gases, and the C-reactive protein also decreasing by day 5 and clearing of pulmonary infiltrates with no adverse effects. And all had deteriorated despite routine therapies at that time. So we would administer only with the hyperinflammatory response or failure to respond to corticosteroids with a high interleukin-6, rising CRP, ferritin D-dimer, or worsening hypoxemia, despite those other interventions that we might be using. Next one.
Guy, your time's up.
Okay. BCG, just very briefly measure it. No difference in positivity in this study in Israel in those that had received BCG and those that hadn't, so probably won't be of value. Next one. Convalescent plasma. The plasma recipients had improved survival, but it was a value of 0.86. It improved survival for non-intubated patients, but not for the intubated patients, so maybe a value there. I think that's the last one. Next one. No, so what would I recommend? Therapeutic anticoagulation, 10A guided, corticosteroids in that dose, vitamin D as a single dose, zinc as a single dose, vitamin C, 500 milligrams TDS, nicotinic acid, 100 milligrams BD, and if clinical deterioration or requiring intubation on admission, tocilizumab as a single dose as well as corticosteroids. And remember that the evidence for chloroquine, Aluvia, Remdesivir, etc., is relatively weak at this stage. Thank you.
Thank you so much, Guy, for that quite comprehensive overview of current treatment strategies. The next speaker was introduced by our publisher, and he showed me his op-ed, Marc Tomlinson from Stellenbosch University, and I was fascinated by it as to how we can change behavior. And I thought it was easy. So Marc's going to actually elaborate on that. Marc?
Thank you, Prof. And thanks for the invite. So yeah, unfortunately, I'm going to basically tell you that it's not so easy, but let's start from there. So I feel a little bit like the interloper here, or the clinical infectious disease specialist. I'm a clinical psychologist by training, mainly work in public health. And so what I want to basically start on the premise that it's likely that COVID's going to be with us for a long time, not the 2 months of Trump or even the 6 months of many vaccine hopefuls. It's going to be there for a while, and that at some level we do need, and I think the initial response of our government was a good one, but we need a shift potentially from virology, infectious disease, not away from, but also to that of behavior change. Next slide. So I use this as an example of Lister and the fight to get people in hospitals to wash hands, just as one example of how difficult it is to change behavior. And there's obviously varying figures, but we know that many hospitals, US, so Africa, elsewhere, that are unable to get hand washing rates above 50%. We also know that there's some data from the US in particular that you can really ascribe up to 70% of all mortality and morbidity to basically 5 behaviors: smoking, alcohol, what food is eaten, how much food is eaten, and exercise. All behaviors, now obviously in food insecure contexts, that's not that's more complicated, but these are behaviors that we know a lot about, we have a lot of information about, and if we look around, it's very clear how difficult it is to change those behaviors. So changing behavior is not an easy thing. Next slide. So I use this model in the op-ed and elsewhere, and we've been trying to help the Western Cape Department of Health, City of Cape Town, and some of their communication. So if you want people to change behavior, and there are many theories around this. This is one of the more commonly used ones, is firstly that people must be able to undertake the behavior. If you're asking people to wash their hands with soap and water, and there's none, that washing of hands becomes impossible. They must be able to undertake the behavior we want people to do. The environment has to then also facilitate the required behavior. Self-isolation, for example, in a one-room shack shared by 6 people is impossible. And finally, people need to have a sense of agency in the world, that making a change, that they're able to, that they're motivated to, and that will have an impact in the world. And this is important in terms of how you message and the kinds of hooks you hook it onto. So for example, if you're a very healthy 22-year-old and you're asking them to protect and to engage in these behaviors, the hook is possibly not going to be their own health, but it's going to be the health of their grandmother or their grandfather, or a commitment to the health of the community. And these are very important things in terms of how you then shape your messages and distribute those messages. Next slide. I like Daniel Kahneman is a behavioral economist. He won the, or actually a psychologist as well. He won the Nobel Prize a number of years ago, and he has a two-system theory of how people think in the world. This is not specifically about pandemics or infectious disease or anything. He's got these two systems, and the one is thinking fast, where it's automatic, it's fast, and it's very susceptible to influences from the environment. The second system is a much slower process, where we're more reflective, where we think more slower, and we take into account goals and intentions. When Prof. Matara spoke about this, when people are feeling anxious, when people are panicking, think system one is operating. People are thinking fast, they're thinking unconsciously. So all the stories around the world initially of hearing about COVID, rushing out and hoarding masks. So which is exactly the worst thing to do, because in a sense, everybody, as you all know, everybody's got to do it, and you hoarding mask is literally the worst thing you can try to do. But when people feel scared and helpless, when people feel scared and helpless, they don't have sufficient information, they don't have the capacity to act. They then also respond in this fast way, and in fact, they may also respond often with defensiveness and anger. Next slide. Many of you may know the work of Richard Thaler, Cass Sunstein. Richard Thaler also won the Nobel Prize for his work around nudge. And this is about how you redesign environments to help with behavior. The advertising industry, supermarkets know all about this. When you walk into supermarkets and you have certain objects at eye level, that's not accidental. You have certain objects lower down, also not accidental. Sweets and chocolates down the aisle, certainly not accidental. They design environments to pull us in. So it's about modifying choice architecture in a way that's not coercion, that's not forcing one to do something, but they can be very, very powerful. So it's not punitive or legislative. Banning alcohol, cigarettes, sugar, that's not a nudge. That's more punitive or legislative. And you're trying to align the environment so that people's immediate choices, perhaps sometimes when they're in that moment of thinking fast, with their rational choices. And so all of you have been into shops now where you've got the markings on the floor where you stand. That's an example of a nudge, and there are many examples around. If you want people to use sanitizers and to wash their hands, make sure that where they're going to, where they are, that's sort of almost in their face. Big pictures of potentially of the virus with hand sanitizer, another way. Very, very importantly, information is not enough. Simply telling people what to do is not necessarily all that effective. It's key, you have to have the knowledge in order to act, and it can certainly, it's important in informing attitudes, but you have to actually find, innovative ways to change behavior. So very often I get at least 2 SMSs a day with more information about COVID. I haven't read them in months, and so passive social media messages aren't that effective. They're receiving one, you get the message after that. There's no more effectiveness in that. That in fact, if you're going to use, and this is one example, and there are lots of them, that if you're going to get social media messages to work, they need to be rich in information, and that information needs to shift and be change and hook the reader in. They also need to be sent at times where uptake is most likely. I'm sure of you, I'm being inundated with webinars, things that I can watch, things that I can learn from. Many of the parenting webinars for parents, for example, of young children, are from 9 o'clock in the morning until 11 o'clock in the morning, possibly the worst time in the world for a parent. So think about when it happens, and also that the more active engagement there is between those sending and receiving the messages, the better. Next slide. So this is utterly key, that if you want communities and you want people to change their behavior, the trust and community engagement is utterly key. That the more things that come down from the top as punitive or legislative, the more you're likely to lose trust. And there's lots of evidence from Singapore's government's experience in SARS, the Ebola epidemic in Africa, that the more you can get involved, local leaders, faith leaders, civic society leaders. On a recent webinar, somebody spoke of the professors of the street, people on the ground who know what their community needs. And if you don't engage those, and you believe that sending dictates from above will get people to change behavior, some things may change initially, but that's not a long-term solution. And there has to be transparent, and the decisions have to be transparent, and they have to be rational. And there's extensive experience from previous epidemics around the world of this. Next slide. And coercion doesn't really work. We like to believe it works, but it doesn't work. You know, there's a level of coercion that obviously maybe, you know, wearing of masks outdoors isn't, you know, there's a level of prescription, a level of coercion. But when you link that with punishment as well, what happens is that the trust that you've built up, the cooperation that you've now bought, as it were, is seen as a breach, and then you lose that most valuable asset you have of cooperation. And if people on the ground aren't cooperating, no amount of laws will make that happen. Next slide. So there are a lot of ideas. I've said something about how you think about messaging. What do you hook in a community? In South Africa, I do, you know, as Dr. Adu said, we have a young population, but I also think we have a population that is very engaged with the elderly population, and it's an important resource. It's an important there's respect for elders. That's the place where you're gonna probably have the most success in holding on to message. It's about your grandmother, your gogo, somebody that your behavior is protecting, as opposed to necessarily yourself. You know, community health workers, I think, are potentially a ubiquitous resource around the country. How do we find ways to get them to, for example, hand out masks? They trust it, get people engaged with that, educate households about hand washing, and then problem solve ways within the community, whether that's by household, by groups of households down a single lane. We need to obviously think about water access. We need to think about creating the conditions or the context to allow people to practice the things that we want to do. We want them to want them to adopt. And I've touched on things like markers on the floor, alcohol-based sanitizers. But just sort of maybe in conclusion, just to say that the changing behavior is an incredibly difficult thing to do, and yet if you look around what's happened in South Africa in the last 3 months, there's actually been the most remarkable changes in behavior. And somebody recently at a webinar, the WHO said that they've tried, they work in the maternal and child and adolescent department, and they said that they've been trying globally for years to get people to wash hands. And they said that COVID, one of the bright things about this is that single-handedly has improved that to rates that they couldn't possibly have imagined of, you know, with 30 to 40 years of work. So that's enough for me. Some thoughts on how we change behavior. Thank you.
Thank you, Mark. Thanks. Excellent presentation. So we've got a very brief time for Q&A. And just to carry on that, Mark, there's a question. So referencing Catherine Campbell's work about the difficulties around behavior changes with HIV, what have we learned that could be replicated in dealing socially with the COVID-19 epidemic? What did we get wrong previously?
Sure, that's a big question. I mean, I think I think we got a lot right. One of the issues that's coming up at the moment, certainly in Cape Town, I don't know elsewhere in the country, but issues of stigma around COVID. You know, that's absolutely key in HIV. I mean, the lessons of HIV around whether it's a civil society treatment action campaign around things from the ground up. I think we have, when I said the initial response of the government, I think there was an amazing coming together, people feeling like it was the right response. I think some of that has been lost for a variety of reasons, but trying to find ways in which communities themselves can find the solutions to something like COVID, to something like HIV. I think very often we come in as the experts with the solutions, but I think we know some things, we can get to a certain point, but it has to be from the ground up. It's about community engagement, civic leaders, religious leaders, religious leaders who in some ways, for example, in this have said, no, we're not going to actually go back to church with 50 people or not. We're not going to do that. We're protecting our congregants. I would say that the biggest lesson has to be that as this pandemic evolves, that much of the solutions are going to come from the communities in South Africa themselves and not experts.
Thanks, Mark. So we probably have a couple of minutes only. Quickly, Warren, what's our status of antibody testing? Short answer.
The status.
Is it going to happen? It's a mess in the US.
No, so it will certainly happen. There's just some finer details being ironed out in terms of its being widely available, and that is through SAHPRA locally, that need to be sorted out. But it will definitely be available and will have a valuable role to play in us dealing with COVID going forward.
Thanks. Guy, 30 seconds. Anything on the horizon that we should be looking forward to?
Well, I think anticoagulation, along with the use of Remdesivir and other anti-inflammatory agents together, may well be of benefit, far more than using the Remdesivir on its own. And hopefully Remdesivir will be available shortly in this country, as licenses have been issued to multiple generic companies at this stage. But no fantastic antivirals as yet. Anticoagulation, we need to look at. Some people are starting to use agents like TPA, but that's very dangerous in terms of the potential for intracerebral bleeds, etc.
Romo, quickly, you think we're in trouble in Africa?
To answer quickly, yes, unless we bring into place the measures to socially distance, to use masks, and to really look at ways of identifying cases and contacts, and then isolating them. So yes, I think we're likely to be in trouble.
You agree with that, Firoza?
I think so. Yeah, I think if we just look at the numbers that we've seen from last week to this week alone, we've literally gone from about 7 to 70 in a week, and that's in hospital symptomatic patients. So definitely, I think our numbers are increasing exponentially with very limited resources.
Yeah, so Warren, your assessment quickly about COVID in South Africa? What do you think is going to happen?
Yeah, well,
I don't know.
all these models, very difficult to say. I think we have certain things in our favor, some things not in our favor. It can change quickly, but yeah, I think to be prepared and to try adapt as we have as best as possible.
Thank you. So I think that the webinar is going to end in about a minute. So before we end, I'd just like to thank all our speakers for sharing their valuable insights into different aspects of the COVID pandemic. These are, as you well know, very interesting but also scary times for so many people. Armed with more clearer and up-to-date information is all we look for. So we are just trying to better to serve the patients we manage on a daily basis. I'd like to really thank Wits Press and Sebinet and certainly my team at the Wits Journal for in fact setting up this webinar, and hopefully we may have a few webinars in future. Just this intro slide was missing at the introduction. So this is a journal that's open to all national as well as international researchers. We had a special issue of COVID in April, which is available online, as you see on the slide. As far as this webinar is concerned, the slides and the link will be forwarded to all the participants. So those who want to record it can see the recording afterwards. And then finally, I'd just like to thank Andrew, Deirdre, and Desmond for hosting this event and organizing the event. So I hope all the participants have enjoyed this webinar, and to the speakers, and I hope you've enjoyed your participation at this time. Thank you very much.
Thank you.
Thank you.
Good.
Good. Thank you.
Thank you.
Thanks, everyone.
Thank